Hello and welcome everyone to today's webinar. My name is Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you to everyone for attending today's webinar. This is the second in our fall leg of the 2024 season. If you are new to our webinar series, a little bit of background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit survivornet.ca. This webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with. We will add a quick Q&A session at the end, but if you would like, put in your questions in the chat function here on GoToWebinar. You should find that on the side of your screen. And now to introduce our today's presenter, Kim Meeking is the co-lead for Queering Cancer, a grassroots partnership aimed at improving cancer care for sexual and gender diverse individuals. Kim is a radiation therapist with over 10 years of experience managing oncology clinical trials, along with 5+ years in the nonprofit sector. Kim holds a master's in clinical and health research, and her interests focus on fostering inclusivity in clinical trials and enhancing cancer care for the SGD populations through community partnerships, rigorous research, and innovative knowledge translation. And so I will hand it now over to Kim for her talk, Improving Care for Sexual and Gender Diverse Communities Affected by Cancer.
Well, thank you. Thank you for the introduction, Trevor. Good morning or afternoon, everyone, from Treaty 6 territory on the ancestral lands of the Cree, the Dene, the Saulteaux, Blackfoot, and the Nakota Sioux people, and the homeland of the Métis Nation of Alberta. Thank you, Jackie and Trevor, for inviting me to present at the CCSN webinar series and talk to you about this topic, which is very close to my heart, both professionally and personally. So these are the learning objectives for our session today. So I'm going to discuss some terminology and healthcare history related to sexual and gender diverse people. We're going to understand the health inequalities related to SGD people with a focus on cancer. And then we're going to identify some inclusive care practices to improve experiences of SGD people navigating cancer care. I'm just going to start off by introducing our organisation briefly, in case you haven't heard of us. So we're a Canadian volunteer-run community partnership. As Trevor said, we're dedicated to improving the experiences of sexual and gender diverse people affected by cancer, and we launched in 2020. And our team are queer, trans and non-binary, and made up of researcher clinicians from the University of Alberta, University of Fraser Valley and Queen's University. There's Dr. Amanda Balderston, who also happens to be my wife, Megan McInnes and Dr. Evan Taylor. And I'm working as the community and content manager. We've also got 2 community partners with lived experience of cancer, and that's Laura Imayoshi and Tristan Bailash. And we're supported by a health communications company from BC called Birdcom. Our website, queeringcancer.ca, features a fully searchable database of over 200 queer and trans cancer specific resources. We've got a curated patient stories page with over 60 stories representing first-hand experiences, including digital stories, comics, articles, zines, anthologies, and more. We've got an education page with links to resources for healthcare professionals. There's also a blog and a newsletter you can subscribe to. We found that a lot of our engagement happens on social media, particularly Instagram. So we regularly develop specific content such as research recaps, collated tips for both patients and healthcare professionals, and occasionally the odd meme or 2. Okay, so let's start with some background information, like terms and a very brief history of healthcare and the sexual and gender diverse community. When we talk about terminology to describe sexual and gender diverse identities, it's important to remember that definitions are not set in stone or meant to be prescriptive. Not everyone will use the same language or have the same definitions, and that's okay. Language is evolving, and the terms we use today might not reflect those that we have used in the past. For example, when I talk about healthcare history, I use the term homosexuality, which is generally seen as outdated today. So you'll notice I'm using the term sexual and gender diverse and the acronym SGD. So this term encompasses all identities captured under the 2S LGBTQIA+ acronyms. So it's inclusive and it's a little bit easier to say. And there's a couple of concepts I want to take a moment to define. The first is heteronormativity. So this is the assumption that heterosexuality is the only normal and natural expression of sexuality, as well as the traditional male and female gender norms or roles. In other words, it's the belief that sexual and romantic relationships must be between a man and a woman. Now, this assumption can manifest itself in many different ways. For example, presuming that a man and a woman are married just because they come for an appointment together. The second is cisnormativity. This is the assumption that a person's gender identity matches their biological sex. And this assumption often manifests itself in the form of misgendering, which occurs when a person is referred to by the incorrect pronouns or other gendered terms. There's some more terminology on this slide. You might have seen this infographic before. Essentially, each arrow is a sliding scale to explain the various facets of our gender identity and sexuality. So the first term is gender identity. So this is our internal sense of being male, female, neither, both, or another gender. Everyone has a gender identity. For transgender people, their sex assigned at birth and their own internal sense of gender identity are different. And for cisgender people, their sex assigned at birth and their gender identity are the same. The second term is gender expression. So this is how we express our gender physically, and it might be through clothing, hairstyle, voice, body shape, etc. And we use terms like masculine, feminine, androgynous, and butch. Sex assigned at birth is the classification of people as male, female, or intersex based on anatomy, hormones, and chromosomes. Physical attraction, so this is our sexual orientation and who we are physically attracted to. And emotional attraction, who we feel romantically or emotionally attracted to. So as I said, the terms we use are evolving, and this resource is not perfect, but it's helpful to provide an overview of the elements of sexual orientation and gender identity. Canada is home to approximately 1 million sexual and gender diverse people, accounting for 4% of the total population, and that's data from the 2021 census. SGD identification has become much more common in the last decade, with many younger adults seeing themselves as an identity other than straight or cisgender. Millennials are more than twice as likely to identify as sexual or gender diverse than previous generations. And recent US data found that nearly 20% of Gen Z identify as part of the community. Older SGD people may have lived through a time when being a sexual or gender minority was against the law before being decriminalised in 1969 in Canada. Knowing a little about queer history is important to understand this experience. In healthcare, being SGD was initially viewed as a disorder that needed to be cured, and this viewpoint is still prevalent in some people and communities today, both inside and outside of Canada. In the late 1800s, influential psychiatrists and physicians like Krafft Ebing and Havelock Ellis classified being gay as a type of insanity or defect. Freud, in the early 1900s, diagnosed same-sex attraction as a neurosis or an immature stage of development. The American Psychiatric Association classified homosexuality as a pathology in the Diagnostic and Statistical Manual of Mental Disorders until 1973. It then took until 2012 for them to declassify being transgender as a mental disorder. So-called treatments for sexual and gender diverse people included aversion therapy, castration, estrogen treatments to diminish libido, and electroconvulsive therapy. An example of aversion therapy is giving people electric shocks or nausea-inducing drugs while showing them same-sex erotica. Then in the 1980s and 90s, the AIDS crisis further stigmatized queer sexualities. Conversion therapy or sexual reorientation is an attempt to convert non-heterosexuals to a heterosexual orientation, or to make trans people cisgender using a variety of techniques. Although widely discredited by the psychiatric community, it is still commonly available in most countries, including Canada, although it is officially banned here. Treatments can be seriously harmful to those that they claim to help. Many people exposed to conversion therapy experience issues including depression, anxiety, social isolation, and delayed coming out. And research has shown that 1/3 of conversion therapy survivors will attempt to take their own lives. A 2023 systematic review found that transgender people reported a history of conversion therapy at a higher rate than gay men and lesbians. Now we'll take a look at health inequalities affecting the sexual and gender diverse community. So healthcare inequalities are differences in health status or distribution of health determinants between different populations or groups, according to the World Health Organization. Essentially, members of disadvantaged groups tend to have worse physical and mental health, including avoidable illness, disability, suffering, and premature death, as well as lower rates of healthcare access. On the right side of the slide is the Wheel of Privilege, which you might be familiar with, and it helps to explain intersectionality theory, meaning that having multiple minoritized identities brings worse experiences of discrimination. For example, a trans woman with housing precarity might face more barriers accessing healthcare than a property-owning cis man. As we've seen, historically, the healthcare system has a rocky relationship with queer and trans people, which leaves a legacy of mistreatment and mistrust. In a Canadian study, over 1/3 of lesbian, gay, and bisexual patients, and over half of trans patients, reported having at least one poor healthcare experience in the previous 12 months. This may cause sexual and gender diverse people to become alienated from the healthcare system and reluctant to seek care, as well as affect how they interact with healthcare professionals and whether they come out or not. So what are SGD patients afraid or concerned about when they experience healthcare, and how do they quantify a poor healthcare experience? So this study by Lambda Legal in the US found that concerns included being refused medical care, being treated differently by healthcare professionals when they come out, and encountering healthcare professionals with little or no training in SGD needs. Worth noting that trans and non-binary respondents expressed significantly greater concerns than lesbian, gay, or bisexual people. And this mistrust may be justified. A 2019 study found that more than 80% of medical students had an implicit bias against lesbian and gay people. So I'm going to pause from talking for a moment and share with you a short film called The Clinic. And this film distills some of the experiences that I've described. It's going to be on for about 5 minutes. And while you're watching, just have a think about some of the assumptions that are made by the healthcare professional in the scenarios.
You have your health card? it's your first time here, can you fill out these forms, please? Please follow me. Doctor will be with you shortly.
Hi, good morning. My name is Dr. Leslie. How are you doing today?
Hello.
Carolina, what brings you in today?
Well, I have been suffering from some pretty intense stomach pains over the last few weeks. And well, to be honest, I always have a hard time deciding like when is the right time to see a doctor, you know?
Okay, Haley. So when would you say the pain started?
Actually, my name's Damien.
Oh.
And I would say, I don't know for sure, about 2 weeks ago, pretty consistently over the last couple of days, and pretty intense pain. And I've tried a few things to manage the pain, but I'm more worried about it becoming a pattern.
Have you had an STI test at all recently?
No, but I've been together with my partner for the last 2 years.
Have you changed your diet recently?
No, I don't think so.
Okay. Any other notable lifestyle changes?
No.
Do you have any accompanying symptoms? Pain urinating at all? Or maybe the pain happens around the same time each month?
Well, I've been on testosterone for the last 4 years, so I don't get a period anymore.
Any nausea or diarrhea?
I mean, maybe some diarrhea, but again, I'm not sure. The pain does tend to flare up seemingly out of nowhere, so.
Well, it seems like it could very well be the development of a food intolerance. I would suggest starting with some diet eliminations, the major ones being gluten and dairy. Just as a starting point, I think we should do an STI test.
Okay.
It's important we rule those out before looking at other options. Why don't you try an elimination diet for at least 2 months, see if it helps your symptoms. If you don't see an improvement or your symptoms worsen, vomiting, fever, etc., enter the ER.
Yeah, okay.
Have a good day.
You too.
And if the pain persists?
Well, the clinic will contact you and get your results back. And if your symptoms worsen, vomiting, fever, etc., head to the ER.
Okay.
Have a good day.
So that short film was called The Clinic, and it's freely available from the getrealmovement.com /The Clinic film. So you can tell that the two patients are treated differently in a number of ways. The healthcare practitioner is making cisnormative assumptions during the consultation and not treating the trans patient equally or respectfully. And unsurprisingly, this leads to a negative healthcare experience for them. And you can see why they would be hesitant engaging with that clinic again and might delay seeking care. So what are some of the healthcare inequalities facing this population? So high rates of stress, high rates of coping behaviours such as tobacco and alcohol use, lower rates of preventative screening and healthcare utilisation, and increased risk of some cancers and chronic health conditions, as well as increased risk of poor mental health and suicidality, particularly in the queer youth. Now, this can be partly explained by Brooks's minority stress theory. So this was first proposed in the 80s, subsequently been tested in over 150 empirical studies. And it explains how marginalized groups, including SGD individuals, experience unique stresses due to their minority status. And these stresses stem from external factors like discrimination, stigma, and violence, as well as internal factors like internalized homophobia or transphobia, and expectations of rejection and concealment of one's identity. And responding to these stresses takes continual effort and adaptation, and then it takes a toll on our well-being. So constant exposure to these stresses can lead to adverse physical and mental health outcomes. Fortunately, there are some protective factors that can help minimize the impact of minority stress. And these include queer community support, being accepted by family, positive responses to coming out, low levels of stigma, acceptance by a community of faith, and having a close network of support outside of biological family, which is called chosen family. And the last few slides are summed up by this quote from a lesbian affected by breast cancer. Being part of a marginalized community brings additional pressures and stresses and the anticipation of potential discrimination or everyday misunderstanding. It's always there. This creates additional burdens which impact on health and well-being. So let's take a closer look over the next few slides at how cancer care is experienced by the sexual and gender diverse population. And I've divided cancer care up into these 5 topic areas. First of all, screening. So there are a number of studies reporting that sexual and gender diverse people are less likely to engage in routine cancer screening. We've got 2 examples on the slide. So data from the US on colorectal cancer screening shows an uptake of 29.3 in the LGBT community compared to a state population rate of 64.9%. Likewise, with cervical cancer, a large-scale database study from the US found that lesbians are over 2 times more likely to report never having been screened for cervical cancer compared with their straight counterparts. In terms of the reasons for the lower screening rates, screening campaigns are often highly gendered, featuring cisgender heterosexual representation. Now, this sends an unintended message to the queer community that the invite is not for them. There's also an informatics issue in that the gender marker on a trans person's health record can incorrectly eliminate them from receiving the screening invitations that they need. And where data is available for screening rates for trans individuals, the engagement rates are universally lower than lesbian, gay, and bisexual population. And this reflects the lack of evidence-based screening recommendations for the trans and gender diverse community. The screening invitations and the procedure themselves can cause gender dysphoria. So this is the distress a person might feel because they have a mismatch between their biological sex and their gender identity. And this causes anxiety over and above the expected anxiety around screening procedures. In general, there's a poor level of understanding about these considerations among healthcare providers. And because of lower screening rates, it's more common for sexual and gender diverse people to receive a later diagnosis. often meaning that their cancer is more advanced and harder to treat. The sexual and gender diverse community are at an increased risk of 7 different cancer types. For example, lesbian and bisexual women are at a higher risk of breast and cervical cancer, and gay and bisexual men are 20 times more likely than heterosexual men to develop anal cancer. Furthermore, gay men with HIV are at 40 times greater risk from anal cancer. For subpopulations such as trans people, there is no current reliable data on cancer incidence and prevalence, and that's because gender identity is rarely captured on intake forms or research databases. I'm just going to share this story from the community. So this is James. James is a trans man, and he'd been experiencing pelvic pain and unexplained vaginal bleeding for a couple of months. His family doctor requested an ultrasound at his local women's health clinic. Fearing discrimination, James didn't show up. I swept it aside until it got to the point I couldn't ignore it. So at one point, James was on the phone to the health centre confirming an imaging appointment, and he was told repeatedly that he didn't have an appointment there because this is a women's health clinic and we only do ultrasounds for women here. And the person on the receiving end of James's call had assumed that James was a cisgender man and that he had the wrong clinic. Finally, after scans and tests were completed, James was diagnosed with stage 4 endometrial cancer. This illustrates why trans folk are so reluctant to engage with the healthcare system and the serious consequences of that. A 2015 study from the UK explored experiences of SGD people undergoing cancer treatment and found the following. Patients dealt with constant assumptions that they were straight or cisgendered. Patients found it stressful disclosing their sexual orientation or gender identity, many choosing not to come out to their team. There was a lack of sensitivity from healthcare professionals and evidence of discrimination. For example, healthcare professionals laughing about a patient's sexual orientation or even offering to pray for them, thinking they could cure their same-sex attraction. They reported a near total absence of tailored support for queer and trans patients, and particularly for SGD caregivers. And no surprise that all of this led to high levels of isolation. In survivorship, queer patients have to adapt to their new identity as a cancer survivor and integrate it with their other identities. And there's growing evidence that the layering of a new identity on top of being queer can compound psychological distress. Recent research has revealed that queer survivors of adolescent and young adult cancers are more likely to experience chronic health conditions after cancer treatment, also more likely to experience poor mental health and health-related anxiety, as well as poverty in survivorship, compared to their cisgender heterosexual counterparts. Navigating survivorship often means continued courses of treatment, aftercare and follow-ups, and there is still very little tailored support, particularly peer support, leaving patients feeling isolated and having to self-advocate. An example of this is Tristan's story. So this is Tristan, our community partner with Queer in Cancer. He's a trans man and ovarian cancer survivor, and he needs CA125 blood tests to ensure his ovarian cancer is in remission. Tristan's gender marker on the healthcare system and all documentation is male, but the lab software restricted the CA125 test to females only, so Tristan's test was cancelled and he was sent away from the clinic, and this happened repeatedly. He advocated for the lab request system at his hospital to be changed to allow the tests to be available for everyone that needs them, and he managed to successfully change the provincial system through his self-advocacy, but honestly it shouldn't have been his issue to solve. When it comes to end-of-life care, sexual and gender diverse people continue to face many barriers and often access care late or not at all. There is a fear that entering the care facility means going back in the closet. And there's an assumption that SGD individuals do not ascribe to spiritual beliefs or practices, which is often not the case. Queer and trans people fear that chosen family will not be respected or recognised as next of kin, and partners also feel unsupported in their bereavement. So this is from a 2016 report called Hiding Who I Am, the Reality of End-of-Life Care for LGBT People. And this is David's story. I knew he wanted a burial and he wanted to be buried next to his mother. He ended up being cremated, which was totally against his religion. I couldn't stop them, but it was like strangers organising his funeral. I was his family, but he never wanted it to be known that he was gay, and I respected that. If he wasn't out, I wasn't out either. I couldn't talk to my family. They thought David was just a friend, and I had nobody to turn to. What an extremely isolating and sad experience that must have been, and impacting their time together at the end and through bereavement too. So we've looked at how cancer care can be a hostile and isolating environment for queer and trans people to navigate in a time of real vulnerability and need. So now let's explore how we can make the system and the environment safer and more inclusive. And these are the 4 areas that we're going to cover: communication practices, policies and processes, healthcare environment, and also education. Okay, so the first area of inclusive practice is committing to using inclusive communication. This relies on not making assumptions about gender, sexual orientation, relationships, or body parts. For example, in a new interaction, you can start by introducing yourself and sharing your pronouns. Then ask the patient, how would you like me to address you? Sharing your pronouns first shows that you're mindful of the fact that someone's pronouns may not match their appearance, and it demonstrates respect. It also helps create a more balanced interaction by offering personal information before asking about them. Use open-ended questions such as, who is with you today, rather than, is that your husband? Trying to avoid gendered terms like husband and wife and use non-gendered alternatives like partner is important to build trust and, again, not making assumptions. A good tip is to listen to the language the patient uses to describe themselves and their loved ones and mirror that language. If in doubt, ask, and if you do make a mistake, apologize, move on, and commit to trying again. When it comes to designing systems, forms, and processes, they should consider the needs of sexual and gender diverse people. Electronic health records and intake forms can be adapted to include these 6 categories: sex assigned at birth, sexual orientation, gender identity, pronouns, chosen name, and intersex status. Given the expansive and changing language around gender identity, it's important to leave space for patients to self-identify and also avoid using the word other as a tick box. At an organisational level, and this goes for healthcare providers, but also non-profits and patient support organisations, it's important to have a publicly available anti-discrimination policy, which includes respect for a person's pronouns, sexual orientation, and gender identity. And there should be a system for reporting any discriminatory or disrespectful treatment and accountability measures to go along with that. Having inclusive systems and policies helps sexual and gender diverse people feel respected and valued. It demonstrates the organisation's commitment to inclusion and supports robust data collection, helping researchers address health disparities. It builds trust and engagement, and it also encourages disclosure. The third pillar of inclusive practice is creating a welcoming environment. So as a queer person, when I enter a new environment, especially one as stressful as a clinic or a hospital, I scan the area for signs of safety. A safe space sticker or rainbow pin or lanyard can indicate to me that I can let my guard down. If I see a healthcare worker or anyone really wearing a pronoun pin, that signals to me that they're a safe person to come out to. Either they're in the community or they're an ally, and I immediately feel a sense of relief. Another really important part of a safe, inclusive and accessible physical space for gender diverse folk is having all gender washrooms. So this ensures that everyone, regardless of gender identity, can access a restroom without fear of judgment or exclusion. And just a word of caution, to be aware of performative allyship. So this would be displaying rainbows or safe space stickers without appropriate education and inclusive policies. And this is a false sign of safety, which can actually be more harmful for the community. In clinic spaces, booklets, websites, social media, or wherever patient information is displayed, it's important to make sure this is inclusive of sexual and gender diverse identities. For example, posters and campaigns about breast cancer screening use a lot of pink and typically only include images of cisgendered and straight appearing women. More inclusive materials would have images of same-sex couples or trans and gender non-conforming people. On the slide, you'll see the Best for My Chest campaign from the UK depicting a trans woman. And this is a good example, and just through this representation, it can help increase screening rates and address misinformation about who needs to be screened. The other example on the slide is from the UK, a cervical cancer screening campaign featuring transmasculine representation. As we discussed earlier, trans men face a lot of barriers accessing cervical screening, such as not receiving invitations to attend if their gender marker is male in the health records. Campaigns like this are crucial to ensure that we begin to close the gap for sexual and gender diverse communities in cancer prevention. And this quote sums up the difference an inclusive environment can make. If I walk into a space when I see a poster on the wall where my identity is reflected, and I see a tick box on a form and know that the healthcare provider expects me in the room, then I'm more likely to access those services again. The last pillar I'll talk about in relation to inclusive cancer care is the need for ongoing high-quality education for everyone involved in the care and support of people affected by cancer. In 2019, the Canadian government published this report on improving 2S LGBTQI+ health and listed 23 recommendations, including promoting education to healthcare professionals on SGD health needs. So many studies that look at the experiences of SGD patients call for more and better education. However, we know that most healthcare professionals have very little undergraduate education about the health needs of queer and trans patients. In 2 studies, medical students averaged about 5 hours in total, and nursing students only 2 hours of curriculum content on queer and trans health. And because education is sparse, SGD patients often end up educating healthcare professionals themselves about their risk factors or health needs in order to receive appropriate care. So my advice to anyone who interacts with patients is don't wait to encounter a queer or trans or non-binary person before you learn about their healthcare needs. Address any personal biases, seek out education to understand structural inequalities and health disparities, and importantly, how to implement inclusive care. There are many places to find further education on this topic, and I've listed some on this slide. On our website, we have an education page. It's got a list of free or low-cost courses from a range of providers. There's some really good resources on allyship from PFLAG. And also, I want to shout out the Princess Margaret Cancer Centre. They have the Sexual and Gender Diversity in Cancer Care Programme. And on their website, pmchosenfamily.com, they have some education modules where you can practice communication in scenarios with diverse patients. Lots of resources there. And there's also a link at the bottom to a great Australian resource written with and for sexual and gender diverse people with cancer. So today has really been an introduction to inclusive cancer care. In summary, the sexual and gender diverse population face inequalities in healthcare and challenges in accessing and experiencing cancer care across the pathway from screening through to survivorship. To close the gap, we need inclusive policies, ongoing education, tailored information, and welcoming environments, all of which play a crucial role in improving experiences and outcomes for sexual and gender diverse people affected by cancer. Included here are the references that were not given in full on the slides, QR code to our website, and Instagram. You can find us at Queering Cancer. Thank you very much for your attention and interest in this topic, and I'll hand back over to Trevor. Thank you.
Thank you very much, Kim, for that presentation. It was a very eye-opening one, and definitely something that is that not many people don't think of, especially when they're interacting with the healthcare system. And some people, I assume, especially in the cancer community, they have maybe not the exact same idea, but they do have this kind of frustration sometimes when dealing with members of the medical community and not taking certain things seriously. So that is definitely something that's, I'm sure some people can definitely relate to. If any of you have any questions, feel free to put them in the questions tab. I'll be reading some off whenever we have more. One question actually, Kim, that I wanted to ask you. With the LGBTQ+ community, there are tons of resources, especially about coming out, what they need to know, et cetera, especially for those transitioning. And I was wondering, from your experience, how equipped are other queer organizations in talking about cancer outside of your own group? What do you find that a lot of people send them your way, or is this a kind of conversation that other groups seem to be have resources of as well?
Thanks, Trevor. Yes, I think we're pretty unique in what we do here in Canada. There is an amazing group in Toronto. I mentioned the Princess Margaret Cancer Centre. They've got a kind of dedicated group there where they provide oncology social work support for queer and trans patients, a lot of resources for patients as well as healthcare professionals, education-wise. So there is a fantastic resource in the kind of cancer sphere. But otherwise in Canada, no, I think, well, I'm kind of glad to say a lot of organisations kind of signpost towards us. There's a group in the UK that are awesome called Outpatients, and there's some amazing researchers doing work there, and also I think on the east coast of the US. But yeah, it's pretty unique.
Excellent. We have a couple of comments that are very uplifting. Calliope, said, "Thank you very much for this webinar. It is so important for me as a cancer survivor, pharmacist, and a mother of a queer son. I cried during the clinic video, but was so happy to view it. Thank you very much."
Thank you very much for your comment. I appreciate you.
And then Rachel also says, "That was a wonderful presentation. I learned a lot and will be diving into some of the resources you provided, so thank you."
Thank you, Rachel. And if anyone has a question they don't really feel comfortable asking, like right now, just reach out, Instagram or email or anyway. So we're happy to chat after this.
And another question for you. Is there a movement in oncology that you're finding that where doctors are kind of taking these examples and taking these issues that you have outlined in your presentation and working for change within oncology? Is there a group or anything of that matter that you're aware of that is kind of pushing for that kind of change in oncology?
I think there's a lot of passionate advocates out there, and obviously queer and trans healthcare professionals working in oncology are doing advocacy from the inside, but it usually comes down to having awesome allies in kind of working from kind of the ground, from this kind of grassroots, to try and make changes at an organizational level, I would say. And apart from the kind of the Princess Margaret folks that we're good pals with, those are the ones that come to mind.
Excellent. Well, thank you very much. And again, if you wish to ask Kim a question through email, we'll be providing an email to everyone who registered for this webinar. And Kim, once again, thank you very much for your talk. It was very eye-opening and very, very, very informative. So thank you very much.
It's my pleasure. Thank you, Trevor. Thanks, Jackie. Thanks, everybody.
Now, this is one in a series of webinars that we are presenting this fall. Our next one is happening 2 weeks from now. We are working with the Lung Health Foundation to bring you a webinar on vaping and cancer. And so be in the loop about that. Just check your email, or you can even look on our website for information about that. Now, if you're not seeing an email in your inbox, please check your spam folders, because we do use a third-party email service. So if you think that you've missed out, just make sure that you check your spam folders as well. Make sure you are subscribed to our newsletter on our website, and do not miss a thing we're doing here at CCSN. Also take the time to subscribe to our prostate cancer newsletter as well. And you can find all these webinars and more at survivornet.ca or on our YouTube channel. So once again, thank you, Kim, very much, and thank you for everyone for attending this webinar. Bye for now.